So imagine you were a student of psychiatric rehabilitation, right?
Yeah.
Or maybe you're actually already stepping into your very first clinical rotation.
Oh, that's an exciting time. Nerve-wracking, but exciting.
Exactly. So picture this. You've just spent 3 exhausting weeks working tirelessly with a patient in a psychiatric hospital.
Right.
You help them stabilize after a really severe psychotic episode, and you put together the absolute perfect discharge plan.
The dream scenario.
Right. I mean, they have their prescriptions in hand. There's a list of community clinic appointments right on their fridge, and they even have supportive housing lined up.
Sounds bulletproof.
It does. You wave goodbye, feeling like you actually moved the needle for once, and then exactly 1 week later, you get the call.
Oh, no. Let me guess. ER readmission.
Yep. They're right back in the emergency room, completely decompensated. The housing somehow fell through. The meds got lost. The clinic appointment was completely missed.
It's so disheartening.
It really is. Yeah. So why does this happen? And, more importantly, what is the architectural flaw in our healthcare system that pretty much guarantees it's going to keep happening?
That is the million-dollar question, isn't it?
It really is. So, welcome to the Deep Dive. Today, we're putting ourselves directly in the shoes of you, the future practitioner.
We are tackling a model that fundamentally changed the treatment of severe mental illness.
Yeah, it's often called a hospital without walls. And we're pulling our blueprints today from 2 main sources.
Right. We've got Chapter 8 of Pratt's Psychiatric Rehabilitation textbook.
And the really comprehensive SAM-HSA toolkit on assertive community treatment, or, as we'll call it, ACT.
Yeah, and that opening scenario you described, it's incredibly frustrating for any clinician.
Oh, absolutely.
Mostly because, the failure usually has nothing to do with the actual clinical science of the treatment.
Right. It's not that the meds don't work.
Exactly. It has everything to do with the environment where the treatment is supposed to be applied.
Yeah, the real world is messy.
Very. And to understand why a model like ACT is even necessary, we kind of have to look at the historical crisis that forced its invention in the first place.
Right. We're talking about the 1970s, right? The deinstitutionalization movement.
Spot on. The policy shift was, it was well-intentioned. The goal was to move the site of treatment away from those really large, isolated, long-term psychiatric institutions.
Asylums, basically.
Right, and integrate people back into the community. So over a fairly short period, the number of individuals living in state and county hospitals dropped by, I think it was over 450,000.
Wow. Over 450,000. That is a massive shift.
It was huge. But the problem was that healthcare planners severely underestimated the sheer logistical challenges these individuals would face.
Yeah, I was reading the Pratt text, and it references a 1986 Newsweek expose titled Abandoned.
Oh, that's a tough read.
It really is. It vividly described how people were just sort of left to fend for themselves on the streets because they released hundreds of thousands of people into community facilities that, they simply didn't exist yet.
They just weren't there. And without the infrastructure of the hospital, this entirely new phenomenon emerged.
Revolving door syndrome.
Exactly. Or recidivism. Patients would experience a crisis, get hospitalized, stabilized.
Just like our student scenario.
Right. And then they'd get discharged into basically a void, and then almost immediately deteriorate and end up rehospitalized.
So the root of that revolving door, according to the sources, is this phenomenon called the diffusion of responsibility.
Yes, this is crucial. Inside an inpatient hospital, every single aspect of a person's life is orchestrated by a single integrated staff.
Right. The nurses know what the psychiatrist is doing. The social worker knows what the OT is doing.
Exactly. They are all under one roof. But out in the community, services were, and honestly often still are, incredibly fragmented.
I mean, a consumer might have one state agency handling their housing voucher.
And then a private doctor completely across town handling their medication.
And a different county clinic handling their therapy. It's like an auto factory assembly line where the conveyor belt is just fundamentally broken.
That's a great analogy.
Like Station A puts the tires on the car, but there's no mechanism to ensure the car actually makes it to Station B to get the engine installed.
Right, because every agency is only responsible for their own tiny piece of the puzzle.
So no one is responsible for the whole person.
Exactly. The housing agency assumes the clinic is monitoring the meds, the clinic assumes housing is monitoring daily living skills.
And the consumer just falls right through the gaps.
Yep. And that exact systemic failure is what sparked the origin story of ACT.
Okay, take us back to the early 1970s. Mendota Mental Health Institute in Madison, Wisconsin.
Right. So A group of doctors there, Marks, Stein, and Test, they were watching this revolving door spin.
Just seeing the same patients over and over.
Yeah. And they realized their inpatient training, all those coping skills they were teaching inside the hospital, were essentially evaporating the moment the patients left.
Because the highly structured environment was gone.
Exactly. But the breakthrough didn't come from a new medication or a new therapy technique.
No, it came from a social worker, right? Barb Lantz.
Yes, Barb Lantz. Unlike the rest of the clinical staff, Barb did not sit in her office waiting for discharged patients to show up for their 2 p.m. appointments.
Because they wouldn't show up.
Exactly. So she went out and followed them into the community.
Oh, wow.
Yeah, she went into their boarding homes. She went to the grocery store with them. She intervened where the daily stressors were actually occurring.
And the doctors noticed that Barb's patients were the ones staying out of the hospital.
Precisely. They essentially realized that they needed to pack up the entire multidisciplinary hospital staff and do exactly what she was doing.
But wait, as a student looking at the logistics of this, it sounds incredibly inefficient.
Yes.
Well, to pack up a highly paid clinical team and bring the treatment to a patient's messy living room, or like a public park, driving all the way across town to see one patient instead of having 6 patients cycle through an office, seems like a massive drain on resources.
Oh, I see what you mean. And it does look inefficient on paper, but that's until you factor in the massive emotional and financial cost of that constant rehospitalization.
Okay, fair point.
The mechanism making Barb's approach work is the concept of in vivo services.
In vivo, which translates to in real life, right?
Exactly. When a clinician teaches a coping skill in a quiet, brightly lit office, the consumer has to mentally translate that skill to a chaotic environment later.
Which is really hard to do when you're in crisis.
Exactly. But teaching a coping skill exactly where the problem occurs fundamentally changes the encoding of that skill in the brain.
Okay, give me an example of what that looks like on the ground.
Sure. So if a consumer is facing eviction because they're having explosive argument with a really difficult landlord, an ACT team member doesn't just talk about it in an office. They go to the apartment building. They stand side by side with the consumer, mediating the interaction, managing the anxiety, and modeling the communication exactly where the stressor lives.
Oh, wow. So for the student listening right now, imagine that shift in your own practice.
Just huge shift.
Imagine stepping out of the controlled clinic environment where you hold all the authority and walking out into the unpredictable streets, into chaotic boarding homes.
You're completely giving up home field advantage.
Exactly. You are no longer behind a desk. You are on the consumer's turf. That completely changes the power dynamic of the therapeutic relationship.
It really does. It levels the playing field.
But, I mean, relying on one rogue social worker hustling in the community isn't a scalable healthcare model.
No, definitely not. To do this for hundreds of people, you need a completely different infrastructure.
Which brings us to how ACT actually operates differently from standard case management.
Right. So standard practice is often called broker case management.
Broker, like a real estate broker.
Sort of, yeah. Like an agent or a travel broker. The case manager assesses what the client needs, and then they refer them out to existing community agencies.
So they basically hand the client a referral slip and say, you need substance abuse help. Go to this clinic on Tuesday.
You need a job, call this vocational agency.
Exactly.
But a referral slip is useless to someone experiencing severe paranoia who is, like, terrified to get on the public bus to even reach that clinic.
Right. The brokering model relies on the consumer having the executive functioning to navigate a really fragmented system.
Which is exactly what their illness impairs in the first place.
Precisely why ACT completely eliminates the brokering.
Oh, they just do it all themselves.
Exactly. The ACT team directly provides almost all the services a consumer needs internally.
Wow. So if the consumer needs substance abuse counseling,
The ACT team provides it.
vocational support,
The team provides it. Psychiatric care, housing assistance, the team does it directly.
that sounds intense. How do they pull that off? Well, the Sam Anches toolkit outlines a very robust, highly specialized, multidisciplinary team.
Okay, what does that look like?
We are talking about 10 to 12 staff members working together. You have the ACT leader, a dedicated psychiatrist, multiple psychiatric nurses, employment specialists, substance abuse specialists.
And crucially, peer specialists. I want to focus on those peer specialists for a moment because both texts emphasize them heavily.
Yeah, they are absolutely vital to the model.
These are individuals who actually have lived experience with severe mental illness themselves, right?
Yes, and the mechanism of how they operate is entirely different from, say, the psychiatrist.
Because a consumer might view the clinical staff with suspicion, like viewing them as just authority figures who want to push pills.
Exactly.
Yeah.
But a peer specialist can say, hey, I know the medication side effects are awful, I've been on them, but here's how I managed it to keep my apartment.
Wow, yeah. They bridge the gap by modeling recovery in a way someone with just a clinical degree simply cannot replicate.
The inclusion of peer providers significantly improves consumer engagement by lowering that exact barrier of clinical distance.
Okay, so you have this 10 to 12 person super team. How many patients or consumers are they treating?
They serve about 100 consumers.
Okay, so a strict 1 to 10 staff to consumer ratio.
Yes. But here is the defining operational feature of ACT, the thing that truly separates it from any other community model.
Let's hear it.
The staff do not have individual caseloads.
Wait, really?
Really? The entire team is collectively responsible for all 100 consumers.
Oh, hold on. When multiple agencies share a client, the client falls through the cracks due to that diffusion of responsibility we talked about earlier.
Right.
If 12 different team members are all responsible for 100 people, it seems like you're just recreating the bystander effect inside the team.
That's a very logical concern.
Like everyone could just assume the nurse checked on the client today, so nobody does.
Right, but the antidote to that internal diffusion of responsibility is the daily morning meeting.
The morning meeting.
It is the absolute heartbeat of the ACT program. Every single weekday morning, the entire team gathers in one room.
Okay.
The SAMHSI text actually features a great quote from Barbara Julius. She's an ACT leader in South Carolina. She describes this meeting as a highly choreographed dance.
A dance. How so?
Well, they use a tool called the Cardex, which is essentially a centralized working schedule and status log for every single consumer.
Okay, so like a master dashboard.
Exactly. In about 40 minutes, the team briefly and rapidly reviews the status of all 100 consumers over the last 24 hours.
Wow, 100 people in 40 minutes. So they're essentially running a daily triage.
Precisely. They are assessing who slept well, who missed a medication dose, who had an argument with their roommate, who has a job interview that afternoon.
And because the whole team is in the room together, they can pivot their entire daily schedule instantly based on acute needs.
Yes, that is the mechanism that prevents the bystander effect.
Oh, that makes sense. Give me an example of how that pivot works.
So, if the nurse notes that John is showing early signs of auditory hallucinations this morning.
The psychiatrist can just immediately adjust the medication profile right there.
Exactly. And then the social worker volunteers to swing by John's apartment at noon to deliver the adjustment.
And maybe the peer specialist plans to take him for a coffee at 3 p.m. to keep him grounded and monitor his symptoms.
You've got it. They coordinate the care for the day every single day, tailoring the intensity of the contact to exactly what the consumer needs in that specific 24-hour window.
I mean, this level of wraparound care sounds incredible. But looking at the realities of our healthcare system, it also sounds incredibly expensive to run.
It's definitely not cheap.
You have a strict 1 to 10 ratio, 24/7 on-call coverage, a dedicated psychiatrist on staff. The immediate danger here is that an agency or a state legislature will look at this model and just try to cut corners to save money.
Well, they definitely try. They'll want to tweak it.
Right.
And that danger is very real. And it is exactly why the field developed the concept of fidelity.
Fidelity. So staying true to the original model.
Exactly. And it's specifically measured by tools like the Dartmouth Assertive Community Treatment Scale, or DACTS.
DACS. Okay.
Fidelity means faithfulness to the original evidence-based recipe. The DACS is a 28-item checklist to ensure a program isn't just slapping the word ACT on their brochure, but is actually doing the rigorous work.
So it measures operational metrics.
Very specific ones. For example, it tracks the percentage of contacts made in the community versus in the office.
Ah, so to score high fidelity, a vast majority of interventions must be in vivo.
Right. Out in the world, not behind a desk. It also measures whether the team retains full responsibility for psychiatric and substance abuse treatment rather than brokering it out.
But let's be real, budget cuts happen.
All the time.
What happens if an agency decides, hey, let's just increase the staff-to-consumer ratio to 1 to 30?
Yeah.
Or they drop the 24/7 on-call coverage and just work 9 to 5?
They dilute the model into what is basically standard intensive case management, or ICM.
And what does the data say about that?
When programs dilute the model into standard ICM, the data is unambiguous. Outcomes drop significantly.
Wow. So you can't just do ACT light.
No. High fidelity directly correlates with success. When you stick to the strict DACTS criteria, the program yields fewer days spent in the psychiatric hospital, vastly reduced rates of street homelessness, and much better employment retention for the consumers.
Because the original recipe works specifically because of its intensity.
Exactly. Tweaking the ingredients fundamentally ruins the outcome.
But looking at the SAM HSA toolkit, it puts the cost of high-fidelity ACT at roughly $9,000 to $12,000 per year per person.
Yep, that's the number.
For a mental health agency, pitching a $12,000 per patient upfront investment to a Medicaid board requires some serious justification.
It does, but the justification relies on analyzing the macroeconomics of the healthcare and justice systems.
Okay, walk me through the economics.
Well, ACT specifically targets the highest service utilizers in the system.
So people who are constantly in the ER or jail?
Exactly. These are individuals who, without this level of intervention, are frequently utilizing emergency rooms, spending weeks in inpatient psychiatric beds, or cycling through the criminal justice system.
And those institutions are not cheap.
Not at all. A single inpatient psychiatric stay can cost tens of thousands of dollars for just a few weeks.
Oh, wow. That makes the mention of forensic ACP programs in the texts really click into place.
Right, like the Thresholds Jail program in Chicago.
Exactly. If you have someone with untreated severe mental illness, they often end up committing nuisance crimes, right?
Yeah, trespassing because they are sleeping in a doorway, or retail theft just for basic survival.
They get arrested, they go to jail, their symptoms actually worsen in a cell, they get released with zero support, and the cycle just repeats.
Forensic ACT intercepts that exact pipeline. When the ACT model is applied to individuals involved in the criminal justice system, it drastically reduces arrest and incarceration rates.
Because it's addressing the root cause of the behavior, the untreated illness and the lack of housing.
Exactly. So while $12,000 a year for an ACT team seems really expensive on a spreadsheet,
it completely offsets the massive burden of $60,000 hospital bills and endless jail costs.
Exactly. It is highly cost-effective because it prevents the most expensive institutional interventions.
Okay, the other operational factor I really want to look at is the no dropout policy.
Ah, yes. This is a big one.
Because I know standard therapy models and managed care rely heavily on arbitrary discharge metrics. You get like 12 weeks of CBT, you show improvement, and your insurance just cuts off the sessions.
Right, you're fixed, goodbye.
But ACT provides time and limited services.
Because severe mental illnesses like schizophrenia or severe bipolar disorder are often lifelong conditions that fluctuate in severity.
It's chronic.
Right. ACT recognizes the reality of the illness. There are no arbitrary discharge dates.
Even if someone is doing really well.
Even if a consumer stabilizes significantly and steps down to maybe just seeing a team member once a month to check in, they remain on the caseload.
So the safety net never disappears.
No.
If that same stabilized consumer hits a major crisis 3 years down the line, they don't have to navigate a complex intake system, reapply for services, get put on a 6-month waiting list.
And hope they survive in the meantime.
Exactly. The team already knows them, has their baseline data, and can just immediately ramp up the daily contact.
They just tighten the net. But maintaining that persistent, time-unlimited presence brings us to the most complex part of this entire framework.
The ethical tightrope.
Yes. We have established that ACT is highly effective, but its very intensity brings up profound ethical questions about autonomy.
I mean, the primary criticism leveled against ACT over the decades is right in the name. Is it too assertive?
It's a valid question.
You have a clinical team showing up at your house uninvited, monitoring your daily medication intake, and sometimes even managing your finances as a representative payee.
Right, meaning the team literally takes legal control of the consumer's disability checks to ensure the rent is paid before the money can be spent elsewhere.
Which is huge. There is a very fine line here between being a persistent safety net and becoming a fishing net that traps the consumer in a web of surveillance.
It is a vital ethical concern. But the texts require us to balance that concern with the clinical reality of the populations ACT serves.
Specifically regarding a neurological symptom called anosognosia.
Yes, anosognosia. It is a condition where the individual is fundamentally neurologically unaware of their own illness.
So it's not just them being in psychological denial.
No, not at all. The frontal lobe deficit caused by the illness literally prevents them from perceiving that they are sick.
Okay, so you have a consumer who is floridly psychotic, facing imminent eviction because they're tearing the drywall out of their apartment.
Right.
And they're telling the ACT team, I am perfectly fine. I don't need your help. Leave me alone.
Yes. And if the team just says, okay, we respect your self-determination and walks away.
That consumer will almost certainly lose their housing, end up on the street, or lose their life.
Exactly. Assertive outreach is medically and ethically necessary to prevent catastrophic harm.
That is such a tough core tension of community practice. You have a duty of care to keep the person safe, but you also have a duty to respect their civil rights.
And researchers have looked deeply into how teams navigate this without crossing into paternalism.
Right. The text cites research by Monahan on the concept of coercion, differentiating between negative pressures and positive pressures.
Exactly.
I imagine negative pressures are the coercive, punitive tactics, things like threatening to withhold a consumer's disability check or threatening to have them involuntarily committed if they don't comply with the meds.
Yes, and those tactics might get a pill swallowed today, but it destroys any trust you have built with the consumer.
It shatters the therapeutic alliance.
It generates fear, which ultimately hinders long-term recovery. Positive pressure, on the other hand, involves persuasion, inducement, and building trust over time.
It is the team consistently showing up and saying, we are not going away. We care about your well-being. How can we help you achieve your own personal goals?
That's the key. The SAM-HSA toolkit emphasizes a recovery-based model to guide this.
Meaning ACT should never be utilized simply to replicate the control of a hospital ward in a person's living room.
Exactly. If the team's only goal is symptom management and forcing compliance, they are completely missing the point.
The goal is to partner with the consumer to define what recovery actually looks like for them.
Right. A consumer might not care at all about reducing their auditory hallucinations, but they really want to get a part-time job.
Or they desperately want to reconnect with their estranged family.
Exactly. The ACT team uses the consumer's self-identified goals as the lever for engagement.
And this is where the integration of the peer providers serves as the ultimate internal check and balance, isn't it?
It really is. Because they have navigated the system themselves, they are uniquely positioned to advocate for the consumer's voice in those morning meetings.
Ensuring the treatment remains collaborative and consumer-driven, rather than slipping into a top-down authoritarian approach.
Spot on.
So for the student listening right now, here is a reflection prompt to really chew on as you prepare for your clinical rotations.
It's a tough one.
Imagine you are standing in a client's living room. They are symptomatic, their life is chaotic, but they are not an immediate legal danger to themselves, and they're flat out refusing their medication.
It happens every day.
How will you balance your clinical duty of care with their fundamental human right to self-determination? How do you remain appropriately assertive and persistent without crossing the line into unethical coercion?
Navigating that gray area is the most difficult and arguably the most important part of the practice.
It really is. Well, let's recap the blueprints we've explored today.
We covered a lot of ground.
We started with the broken assembly line of early deinstitutionalization, where fragmented care left hundreds of thousands to navigate the streets alone.
Right, and we saw how the frustration of that revolving door led to the creation of a hospital without walls.
Prioritizing in vivo services where the stressors actually happen.
Then we looked under the hood at the machinery of the multidisciplinary team, the shared caseloads, and the critical daily triage of the morning meeting.
That dance that ensures no consumer falls through the cracks.
Exactly. We examined the necessity of high fidelity through the DAX scale, proving that doing the intensive work up front offsets the massive economic costs of the forensic and hospital pipelines.
And finally, we walked the ethical tightrope, balancing the duty to assertively protect vulnerable individuals with the absolute necessity of honoring their autonomy through positive persuasion and recovery-oriented goals.
To close out our analysis of these source texts, I want to leave you with one final thought to mull over regarding the environment of care itself.
Okay, let's hear it.
The strengths-based model of case management views the community not as a barrier to be managed, but as a treasure trove of resources to be utilized.
I love that framing.
Right. But if the ultimate success of an ACT team depends heavily on the health and availability of the community it operates within.
Like the availability of affordable housing or inclusive employers or welcoming social spaces.
Exactly. If it depends on all that, then what is your role as a future practitioner? Are you merely a clinician treating the individual, or must you also be an activist and an advocate?
Oh, wow.
How will you actively cultivate those resources in the community itself so that your clients actually have a healthy, functioning world to recover into?
That expands the definition of psychiatric rehabilitation far beyond the clinical text.
It really does.
Because if we look back at that opening scenario, the perfect discharge plan that fell apart in a week,
Yeah.
maybe the plan didn't fail because the medical science was flawed.
Maybe it failed because a hospital without walls still requires a solid foundation in the community to stand on.
Absolutely. Keep questioning the systems around you. Keep exploring the material, and we will catch you on the next deep dive.